I'll just add, I think to your point, the perception that there was a conflict, whether right or wrong, I think has invited more government regulation of the practice of medicine in this setting. And you see the implementation of more Part B rules around the provision of oncology products precisely because there's a perception in CMS that doctors are, quote unquote, conflicted here and we need to step in to regulate their decision making. That's unfortunate. And it's another thing to think about as we contemplate a different system.
And I think that there's a little bit of an irony here too, because I actually totally agree with you, Mike. I think that in the process of what we are all doing and working on, and especially with that in terms of the oncology medical home, and looking at payment for quality and value measures and having real measures that we've agreed on, a team that involved your colleague, Dr. Klein, and other providers and even patient entities in terms of agreeing with open set models. The problem is that the system is very efficient. So what we have to do is we have to jointly, as we look at oncology payment reform models, the oncology medical home, is to say, where do we have those opportunities of providing the best efficiency of the system and basically trying to twist what's being done in terms of reimbursement now to make it work. Let's not forget about something. As you all know, COA tracks, and we've done it for 8 years now, 5 years, what we've gone back 8 years, practices that have closed facilities, that have migrated to the hospital. And those numbers are as clear as daylight. I mean, we have upwards of 450 practices involving multiple sites over the last 8 years that have gone into the hospital, merged into the hospital setting. We have close to 350 cancer facilities that have been closed, especially in rural areas. So the fact of the matter is, economically, if this was still a very much an attractive model, just sort of on the economics itself, you would not see that trend. You wouldn't see a united experiment that was specifically designed to take away the so-called drug incentive. And what you didn't mention, Mike, and as you well know, is what happened? The drug spend went up 279%. Now, there are a couple structural reasons, but there are some other reasons that happen to do with when you're on the hook for that drug. Basically, you think very differently about it when you're not. And I'll tell you where this comes about. And we have another experiment. I don't want to go back to this, but 340B. What's the difference in terms of just because it's a hospital? And so if you look at, a very large integrated practice like Florida Cancer Specialists, you look at Moffitt, what's the difference between the two? Other than that Moffitt gets special pricing and other hospitals down there get 340B. So what you see there is a situation of, what do we see? We see, because of the 100% margin on drugs, and if you look at studies by Avalere, the Moran Company, Milliman, what you see is the same picture. There is more drug, more expensive drug being used in that setting than on the community setting where you would say, oh, they're using more expensive drug because they have this plus 6% on ASP. So I think we have more and more data which presents a very interesting picture about what physicians do or don't do or think about in terms of the incentive and where it really exists, which is on the hospital side.
So I'll just want to